So our first speaker tonight is Dr. Dimitry Lerner, who is a gynecologic oncologist with Cyprus Women's Cancer Treatment Center. Dr. Lerner, thank you so much.
All right, thank you very much. Thank you, Margaret. Thank you for coming, and thank you for organizing this. So what I'm going to talk briefly is basically about gynecologic cancers and just the scope of the problem and the scope of treatment options that we offer, and kind of give you a brief overview and touch on some pertinent issues that have been, perhaps some of them may be controversial. So I wanted to start with just an overview of incidences and percentages of new cancers, gynecologic cancers that are, or women's cancers that are diagnosed in the United States. And as you can see, the number of cases, of new cases, and the number of cancer deaths are different. They are not, they're not in the same order. Even though breast cancer is the most prevalent cancer, with 1 of every 8 women with 1 of every 8 women over a lifetime diagnosed with breast cancer, the deaths that are caused by breast cancer are 14%, where ovarian cancer is diagnosed in 3% of women, but is responsible for a larger number of cancer deaths. The ovarian cancer is one of our main enemies as a gynecologic oncologist for several reasons. One is the symptoms can be subtle, and sometimes you may not have any symptoms, and they're vague. The symptoms of ovarian cancer are very nonspecific. You can have pelvic pain, abdominal pain, bloating, difficulty eating. These are very nonspecific, kind of vague symptoms that can be attributed to many different things. However, the awareness needs to be raised if these symptoms are persistent and frequent. If you have a heavy meal and you feel bloated, that's most likely not ovarian cancer. If that is persistent and lasting for months at a time, then definitely that's something that needs to be brought up, and at least the possibility of this being related to the ovaries needs to be entertained. Even though it's pretty rare, it still needs to be on the differential diagnosis. The lifetime risk of ovarian cancer is 1.6%. And that's about 1 in 70 patients will be diagnosed with ovarian cancer. There are several risk factors for this. One of the theories is incessant ovulation, meaning continued ovulation can result in spontaneous ovarian cancers. And one of the theories come from actually observing chickens. Chickens, as you know, ovulate pretty regularly. They lay eggs about once a day, and some of them can develop cancers which are similar to ovarian cancer in appearance. The other factors that support this theory of incessant ovulation is the fact that women who take birth control pills, and as you know, birth control pills prevent the ovaries from producing eggs, and prevent ovulation, those women have reduced the risks of ovarian cancer. And if you use birth control pills for 10 years, your risk of ovarian cancer decreases by half over baseline risk, and that decrease in risk persists for up to 10 years after you stop the birth control pill. And also women who who are multiparous, meaning they have given birth multiple times, have lower risks of ovarian cancer than women who are nulliparous, who haven't given birth, because the theory is that when you're pregnant, when you're breastfeeding, you cease ovulating and kind of give your ovaries a break. let me go back to ovarian cancer and just talk, Dr. Chen is going to talk in more detail about the treatment paradigm. But essentially, the diagnosis is made based on several factors: symptoms, the characteristic findings on the CT scan, some tumor markers that can be important. A lot of you know about CA-125 levels. I want to mention that right now there is no screening test for ovarian cancer, except in situations where there's family predisposition to ovarian cancer, meaning if you have a strong family history or you're known to be a BRCA1 or 2 carrier. In those situations, screening with ultrasounds and CA-125 levels can be indicated, but right now there is no screening test for ovarian cancer. So random CA-125 levels are really not indicated. And in big studies that have been done in England and in other places, they haven't led to discovery. They haven't led to discovery of new cancers in patients, but what they have led to is a lot more surgeries that are being done for benign reasons. Endometrial cancer. This is another cancer that is pretty common. As you can see, the lifetime risk is about 1 in 38. The risk factors for endometrial cancers are unopposed estrogen, as well as genetic risk factors. And I'm sure you're going to hear more about that, the genetic predisposition, later from Margot. The endometrial cancer is kind of our, you can say, success story. It presents in early stage because there's a very bothersome sign, which is vaginal bleeding and postmenopausal vaginal. In a woman who's postmenopausal, who has vaginal bleeding, alarm bells go off, and that triggers kind of the workup for endometrial cancer, which can be diagnosed with ultrasound endometrial biopsy. Usually, what happens then is the patient goes to surgery, and what's done is a hysterectomy, removing the ovaries, sometimes lymph nodes, and that gives us a stage, meaning we know if the tumor is confined to the uterus, or if it has spread to the ovaries or the lymph nodes. And many times these situations, these cancers are curable just with surgery alone. Sometimes adjuvant therapy is required, which is either chemo or radiation therapy. But many times for early stage endometrial cancer, the survival is in the high 90s. And we in this country have a little bit of an epidemic of endometrial cancer, and this is due to obesity. And as you can see in the state, these are the colored map that shows the highest number of obese adults in the United States, and and those states have the highest rate of endometrial cancer because adipose tissue converts androgens to estrogens, and estrogens stimulate the endometrium, and endometrium under estrogenic stimulation can turn into carcinoma. Cervical cancer in this country. This country has implemented the Pap smear screening program, which has been really highly effective in decreasing the incidence of cervical cancer. But in other parts of the world, this is one of the leading causes of death in women. And these countries, places like Africa have a really high rate of cervical cancer. Because of Pap smears, because of HPV vaccine, which is becoming more common, the incidence of cervical cancer is really declining in the United States. cervical cancer is related to the HPV virus, and there are many HPV viruses, but the two types that are related to cervical cancer are HPV 16 and 18, and they cause about 70% of cervical cancers. And these are the two viruses that are in the HPV vaccine. So what's recommended now is for girls between the ages of 9 and 26, and I believe for boys now too, is to give the HPV vaccine. And there's the concept of herd immunity, with that if you immunize both the carriers, which are the males, and the females, you could potentially eliminate or significantly reduce the incidence of cervical cancer. And some countries have already implemented this vaccinations for the whole populations, such as Australia. They vaccinate all of their girls and boys with the HPV vaccine. There are two different types of vaccine, but essentially both of them protect against the high-risk HPV, which causes cervical cancer. The Pap smear recommendations have recently changed, and I just am just showing them to you here. The guidelines have changed to not doing Pap smear yearly, but doing it every 2 years. That's because the timeline of cervical cancer, it really develops over time. From dysplasia meaning from abnormal cells to cancer, it can take up to 10 years. And that's why with screening, with frequent testing, we can catch a lot of the dysplasia, these changes early, and treat it, and thereby reduce the incidence of actual cancer. And after the age of 30, if the patient had normal Pap smears, the screening interval can increase to up to 3 years. Let me just briefly talk about different, in terms of, I talked that endometrial cancer is treated with surgery, and there are different ways to perform this type of surgery. One way is doing a traditional surgery where you make an incision from pubic bone to the umbilicus and a little bit above in the midline, and do a surgery that way. Another way that we're doing it now is using something called the Da Vinci or robotic surgery, where you make a small incision around the umbilicus, place a camera, place a few more ports on each side, and do the same procedure that way, under three-dimensional visualization using this tool, which is the tool of Da Vinci, and that significantly decreases the length of stay. Instead of staying 4 days, 3 or 4 days in the hospital, the patient could go home the next day, and really improves the recovery with having the same oncologic outcomes. So that's kind of one of the big surgical advances for endometrial cancer. So I would say probably 90% of our endometrial cancer surgeries are done using the robot. There are certain situations where we don't do it, but those are few. And I think I'm going to finish up here. I'll take this. I just kind of gave you a brief overview. I'm happy to answer some questions at the end.